live in a, however you cut it, what's that old James Brown song? It's a man's world.
Oh, yeah.
And, there's a very, the way our entire culture is set up is really around strive and drive. And
Dr. Aviva Romm, I am just thrilled to welcome you to the Better Show. Welcome.
thank you so much. I'm so excited to talk with you today.
Yes, me too. And I have to tell you, when I reached out, and I originally reached out to your team, I think in my message, I had said something like, I have been following this woman for decades. Like your books, Natural Healthy Children and Babies was basically my Bible when I was a new mom. And then you also wrote another book with Ina May Gaskin, the pregnancy.
Yeah, she wrote the forward. Yeah, the
natural
pregnancy book.
Yes. And so these really have profoundly influenced me as a mother, and as a doctor really as well. And when I heard that you had this new book, Hormone Intelligence, I knew that I wanted to reach out to you to tell this to you publicly, but also to have your wisdom on our show, because it's a lot of what we talk about. And I'm just thrilled to have you here today.
Thank you. I'm so grateful for that. I really, it's very moving. Thank you.
You're welcome.
I wrote that book, that natural pregnancy book. I wrote that book in handwritten notebooks I started it when I was 22, and I'm turning 55 in 2 weeks. So it's such a powerful reflection to hear that it's influenced you and influenced people for so long.
Yeah. And so I would love, as we're going to talk about your new book, Hormone Intelligence, and there's such a wealth of information it's truly, I said, it's truly a Bible. Like this is such a must have, I think, in every woman's arsenal. And just before we get into that, I think it would be really to provide some color and grounding in terms of your history, because you are both a midwife and a medical doctor. So for those of my audience members who are not familiar with your work, tell us a little bit about, becoming a midwife, and then the impetus after that to say, you know what, I also want to combine this with a medical degree.
So I actually started out going to college to be an MD when I was 15. I got accepted to college when I was 14. It's a whole story about kind of getting out of a bad neighborhood and getting a phenomenal scholarship. And so I was on my way to becoming a medical doctor, and my first semester in college was a very liberal New England school. I got exposed to home birth midwifery, herbal medicine, organics, kind of just this whole back to the land thing happening in the very early 80s. And I fell in love with it. And I thought, okay, like this is the answer to so many of the global cultural challenges that we're facing. I mean, I was already thinking about the climate. I was already thinking about the environment, back then. And so I left school, apprenticed myself to a midwife, studied everything I could get my hands on herbal medicine, which back then was so fringe. I mean, there were like just a few books published. So, like kind of knocking on doors metaphorically, but cold calling herbalists around the country saying, can I talk to you? Can I ask you some questions? Can you like lay your wisdom on me? And one thing led to another, and I ultimately had a practice as a midwife and a practice as an herbalist, which was very exciting and rewarding and nourishing and wonderful. But it was before the inflection point that we're in now, where more people are aware of natural therapies. This was still very much at a time when things were extremely polarized. You either were like super outside the box, probably kind of a hippie back to the lander and using herbs and thinking about home birth and healthy food, or you were pretty much in the medical model, and there wasn't any in between. But when people who were more natural did have a child with an ear infection, or needed to transport from a home birth, or had a pregnancy with complications, or had a menstrual or gynecologic problem, and they needed to go into the medical model, they were so foreign to it. And often the medical model back then was very judgmental of people going from that other place. What, you didn't give your kid an antibiotic yet for the ear? Do you want your kid to be deaf or die? Like, we literally used to hear these kind of things. Now we know for most kids' ear infections, you're actually supposed to wait and watch so that you don't, breed antibiotic resistance and overtreat. So things have really come in a big circle. But that was a huge impetus for me to be that bridge and go into the medical system. One, to be that safe haven for people who wanted to, who needed to get medical care or wanted medical care for something, but wanted to have somebody that they could trust and get information they could rely on from. But I also wanted to change the medical system and, how women are treated, how birth is treated, how pediatrics is treated. So I now, 4 kids in tow, applied to med school and went to Yale, which was my big choice. I really loved so much about that med school. And I did 4 years at Yale in medical school, a year of internal medicine residency, and did family medicine to complete my residency, because I really wanted to bring in the obstetrics and pediatrics. And ever since, I have been kind of just marrying those worlds, educating in the medical world, educating people who are in the medical world but want to do things differently, educating women who want to take back their health, educating mamas about pregnancy, birth, and their children. And, it's, some people say, oh, like, you've had a second career. And for me, it's not. It's just been this like one thread with these different ways of it manifesting, these different parts of my education and evolution. And, for sure, the MD gives a level of opportunity and credibility to amplify that message and start to bring more normalization to the conversation around home birth, or any of the number of things that I know we're going to talk about today around hormones and gynecology. But that's basically my story. I have been with my same partner for 37 years. My kids are 27 up to just turned 36. I have 2 grandchildren who I also had the good fortune of midwifing at home. I practice medicine. I'm licensed in New York State and Massachusetts, but I do telemedicine for people all over the world, actually, write books and teach online programs. And then my newest book, as we talked about, it just arrived. It literally just arrived. So this is the first time I'm showing it publicly, except my little happy dance and stories. But this is the latest book, baby.
And I'm so excited to talk about it because, as you were just saying, it really, your career has really been a blend of this sort of ancient wisdom and, botany and herbal medicine with modern science and modern medicine. So let's talk a little bit about the book. So the new book is called Hormone Intelligence, and there is so much to unpack here. So, we're going to talk about menstrual cycles. We're going to talk about the HPA axis, the HPT axis, the HPO, like there's all the places that we can go in this conversation. But I wanted to start with what I think is the single most important conversation. And we were talking a little bit about this in the pre-chat, which is how we can begin to potentially coach and empower women to advocate for themselves in a more classical, we'll say more stringent allopathic model of care.
Yeah, I mean, it's very hard when we have a health concern, particularly, and then we go into the medical model. It's a setup for power differentials, right? We're already feeling vulnerable and concerned about something going on. And now we're going to someone that we have hopes and expectations that they're going to have time for us and hear us and calm us and give us answers. And so then what happens is frequently, and there's some, of course, some wonderful physicians out there, but what frequently happens is that your physician has you and 25 or 30 or 39 other patients in a day. It's not uncommon for a busy practitioner to see 40 patients in a day in a conventional medical practice. And what happens, you go into the office and you go into the exam room, your nurse comes in and says, put on the gown, right? So that you're ready for your exam. So now you're in this gown that makes you look just like everyone else. Your back end flapping open, you're feeling vulnerable. You're in this very sterile environment usually. And then you're sitting in a chair, waiting. And then the doctor comes in and is fully dressed, in their work clothes, often a white coat, a stethoscope, all these signs of like professionalism. Often the way we're situated, the physician is behind a computer, maybe not looking at you continually. It can be very alienating. I make sure, for example, in my practice that my patients are always physically sitting at least on the same level as me, not lower. But I've been in situations where a physician is literally physically elevated. So this power differential happens, and it makes it very hard if you're already feeling vulnerable. And then add to that, maybe you're not the most outgoing person, and your doctor is also rushed. So the average physician has 15 minutes with us. And we know that the average physician statistically interrupts their patient within 90 seconds to 3 minutes of the medical appointments. And now you're like, like you want to say something. So how do we bridge this gap? And then also it may be that you have vague symptoms that you're not really sure what to do about, like what to make of them. Maybe you are really nervous. Maybe you just get really nervous speaking to authority. And so what happens? Often we don't get our concerns expressed. Maybe you're looking for alternatives and you're feeling really awkward because you know your doctor doesn't actually approve of them. Maybe they're not a doctor who values that, and maybe you're even afraid they're going to diminish you, and maybe that's even happened before. And maybe you've had lots of previous medical appointments, and so now you're anticipating not getting the help that you need and you're frustrated. So from your doctor's point of view, we're trained in very conventional medicine. We're trained to be skeptical of alternatives. We're trained to kind of give the little bit of eye roll and say, oh, it's that kind of patient, when they've read something on the internet or Goop or somewhere else. And we're like, oh, that kind of patient. I mean, really, this is the attitude a lot of times. And we're also dealing with our own stresses, and we know we have 15 minutes and 30 other patients waiting, and then all the phone calls. So there gets to be, and then also if you're in that gown and you're like number XYZ in that doctor's day, you can also start to look a little homogenous, right? They lose track of the person in front of them. So this can be a real recipe for like a very bad date. Like you're just not communicating and you're not hitting it off. But unlike a date where you could walk away, you're actually depending on some information. So I recommend a number of things. One is understanding and knowing all of this ahead of time so that you are prepared to troubleshoot the situation. So one thing is, when you go into that, before you even go to your medical appointment, be very clear as you possibly can, what you're going for and what you hope to get out of it, and really write that down. Like bring a couple of index cards or a notebook, and don't bring it on a tablet or something, because if you realize you're out of juice and you're like, now I don't have my information. So bring it on something written and have it with you, and have it literally say like, I've been having periods every 2 weeks and they're really painful and I'm getting headaches. Or write all your symptoms, how long they've been happening for, what you're concerned about. Like, what are you worried about? What's your worst fear? What are you hoping to get from this appointment? I really just want a diagnosis, and I want your thoughts on what I might do about this. And I'm also I've been reading about this on Dr. Aviva's website or, WebMD or somewhere. And I'd really love to have your thoughts on it. The more you have that just clearly written down, keeping in mind it's a short appointment, what are your top priorities, and having that script. And then when you go into the medical appointment, rather than changing into that gown, if that's what's expected of you, before you have that conversation, let the nurse know, I'm happy to change into that if there's an exam needed, but I'd really want to start out with a conversation first. That's going to make me a lot more comfortable. They're not going to, they may give you a little attitude or huffy, but that's not your problem. That's their problem. Have the conversation. Let that primary doctor know, let that care provider know that you get a little nervous, that you have a lot of concerns, that you've written them down, and that you're actually going to use the script because you want to respect their time and stay on track. And yes, you are managing their ego, because if it is a doctor who's trained to disregard patients, which is quite sadly often the case, they'll know, okay, I'm respectful of your time. I really want to get these questions answered, and I really want to hear what you have to say, and want to make sure we get to whatever your agenda is too. And so read those questions. And then if there's a need for exam, then you can change. have an advocate with you. It's a really powerful tool, but that advocate needs to be somebody who is comfortable with power. And so if it's your mom, unless she's like an ardent feminist or something like that, a lot of our moms are going to be like, oh, honey, especially depending on their age, like just do what the doctor says, or like listen to the doctor. That's not what you need. You need someone who's there for you.
Right.
You need someone who's like elbowing you if the doctor's interrupting and reminding you, no, you have some things that you needed to say, or she might say that, like, don't forget you wanted to ask about this. And also acts as a witness. And I don't mean a legal witness. I mean, most of us behave better when there's somebody else in the room. So the chances of you're being mistreated or disrespected are lower if there's another person who's there on your side. If you have a boyfriend or male partner or husband or just a male friend and it's a male doctor, sometimes there can be some bro-y dynamics that happen that don't always serve to your advantage. But similarly, if it's a male partner and a female doctor, there can be some funny dynamics that I've seen happen and play out that way too. So I recommend a trusted woman or same gender friend to you that you're going to feel really comfortable with. And those are my big items. I would say if you're in there looking for answers that you haven't been getting easily, bring some articles with you, 1 or 2 articles. So let's say you have a thyroid problem and you've gone to your doctor or another doctor in the past and you're like, well, you've had thyroid labs and they're fine, but you're looking at a website like mine or like yours and you're seeing, oh, there's actually something called optimal thyroid ranges and mine are actually outside of that. Print out an article from either a medical journal. It's why I always give references in my articles, or print out an article from someone like me or WebMD or somewhere. It doesn't, WebMD is just coming to mind. It can be Healthline, anywhere that you feel like has some reasonable reputation to it, and bring that with you. And again, you might be managing an ego, right? You might be managing someone who has an expectation that people who are looking for alternatives or asking about their own labs are difficult patients. Women are commonly labeled as difficult patients. And here's the challenge too, is that certain medical conditions like polycystic ovary syndrome, endometriosis, thyroid problems, a lot of autoimmune conditions in addition to Hashimoto's, which is the thyroid one, have symptoms that are classically brushed off as anxiety, stress, neurosis, hypochondria, all kinds of things. There's just being a woman.
Yeah.
Yes, or just being a woman.
Right.
And the more doctors you go to get answers, the more each subsequent doctor thinks of you as a difficult patient. That is statistically borne out. So I would highly encourage, if you had previously bad experiences with other doctors, stay away from that. Actually, it's unfortunate that you can't speak your truth. I mean, obviously, if it's like a physician like me, I want to hear about it. But I had a patient who applied to be in my practice at one point, and she started telling me in an email, like paragraphs of an email about a previous doctor that she had gone to, and he got divorced, and he was, it was like so much. I thought, okay, I don't actually feel comfortable with this patient because she's ragging so badly on another doctor. What if she goes to the next doctor and is just ragging on me? So be aware of that. And again, I don't want to suppress you. I'm just telling you as a physician insider, these are the kind of things that get doctors' backs up. And I've had that particular experience, but in general, I mean, I understand why people go from doctor to doctor, because most doctors don't have the information and don't give you the answers. So expressing it, but in a way that's not like dissing other doctors, can help your cause more. And if I always say, look, if you were to hire a decorator, let's say you bought a new house and you could afford to decorate it, and you hired a decorator and you told that decorator what you love is mid-century modern, and everything your decorator brings to you to show you, like the fabrics, the swatches, the images, is all country French, you're either going to say to that decorator, you're really not hearing what I'm saying, or you're going to get pretty quickly to a point where you realize you have the wrong decorator. And I would hope that you would let that decorator go rather than pouring money into someone who is not meeting your needs or telling you that you should like something different than you actually like. But we don't act the same way with our physicians, partly because we are vulnerable when we're not feeling well. But it is really important to create that partnership model where you're saying, I want to be a partner in my health. This is what I value. This is what's really important to me. And I'm here because I want to hear what you have to say, but I also really want to have my preferences respected. And if you are mistreated, then going to another physician or another type of provider. It also doesn't have to be a medical doctor. You can go to a nurse practitioner, a nurse midwife. There are some wonderful licensed naturopaths. I know in Canada and here in the US, at least, you can find alternatives that can also get you what you're looking for without some of that entrapment that comes with the medical model training and the medical model experience. So those are, I mean, long answer, but those are some of the really important pieces that I think can really make a difference in your experience. And, go in expecting to have a wonderful experience. So you're not creating a negative self-fulfilling prophecy. You don't want to go in with like an adversarial attitude, but go in open-minded and realistic as well, so that you're prepared for all scenarios. And hopefully you have a wonderful one. But if you need backup, you've got that advocate, you've got your script, etc.
I think that's excellent, because then it really takes the onus. Women, I mean, you talk about this in the book a little bit. We always blame ourselves, right? Like something went wrong. There must be something wrong with me. So when you take an advocate with you, whether, the same gendered advocate, as you mentioned, then you can say, was it me, or was it, was there something that and then you can have that reflection. And you also take the onus off of yourself, and you say, okay, this may or may not work. I'm going to present this, and I'm going to speak his or her language, and I'm going to bring in some studies. And, I at this point, in my career, I often will hear, easily weekly now, women will say that, they were brushed off, they weren't listened to. So I'll say, bring data. This is the language that we speak. If you say, listen, if you bring in your period, your cycle charting, whether you're doing FAM or, fertility awareness, cervical mucus charting, or you just have, the Clue app or something on your phone, you can say, listen, I'm getting my period every 2 weeks, as you said, I'm bleeding. There's every time I bleed for the last 6 out of my 9 cycles, bigger than a quarter. I see these clots in my, so then you're able to really speak more specifically, as you were saying, and you're much.
Exactly.
Yes.
Yes. And also I think we have such a tendency to gaslight ourselves, right? We get gaslighted like, well, that's normal, or I'm sure that couldn't be happening, or I'm sure that could not be a side effect. That depression could not be a side effect of your starting the birth control pill, but it is, right? It often is. So having that data really is indispensable, but it also can remind you to stay in your truth, right? I always say to my patients, and I say to my students, and I say to women online, no matter how much medical education any doctor has, you know your body better than anyone else. And if you know that you're cycling, you're having your period every 2 weeks, it's not normal. And having that data can remind you, yeah, something's not right here. And I do agree. I mean, physicians should be looking at that data and taking it really seriously.
Yes. One of the things I've seen you say online, it's also in your book, you say being a woman is not a diagnosis, which, I think is so profound, because we often are told, oh, you're in your 40s now. That's what happens,
You're a new mom. It's just, it's normal to be that tired. Oh, you're a new mom. It's normal to not lose the baby weight. Oh, actually your thyroid? Never,
right.
Maybe it actually is. Yeah. I really feel like so many of these diagnoses that are just like, well, it's because you're a woman. Well, no, actually.
Right. And so there's this medicalization generally by medical practitioners, there's more conservative, more conventional allopathic doctors and big pharmaceuticals. Can you explain, what that medicalization tends to look like in practice? And then from there, I'm deliberately bringing this up because I want to talk about the exposomal science that you present as a more of a holistic way of looking at women's healthcare.
It was actually a really interesting challenge writing the book, because on the one hand, I'm encouraging women to make sure that they get diagnoses for things when they're not going right? Like if you have cystic acne and you have unexplained weight gain and binge eating and depression and irregular cycles, it's really important to make sure that you get a diagnosis if you do in fact have polycystic ovary syndrome. If you have chronic, pain every month with your period or in between and symptoms of endometriosis, it's really important to get a diagnosis. So on the one hand, I'm pushing for women to make sure that they do know when something is wrong, what it is, so they can do things about it. But on the other hand, there has been just this absolutely rampant over-medicalization or medicalization period of things that are actually completely normal. So childbirth, is a prime example. Having a longer labor than fits the standard parameters, which are way too narrow, we end up being told that we're not progressing. It's called failure to progress. I think there's a lot of woman-blaming language like that, failure to progress. Now it's called labor dystocia. But only in recent years was that changed because the failure was such a negative term that blamed the woman. But then it's like, okay, well, then you need the Pitocin, then you need the epidural. Okay, well, it's not happening fast enough. You need the C-section. Or another classic example is the normal changes that women go through in perimenopause and menopause. We're not meant to have high levels of estrogen circulating through our bodies our entire life. We're meant to start having that estrogen come online when we hit puberty, and we're meant for that estrogen, that stronger form of estrogen, estradiol, that accompanies us through most of our reproductive years, to go offline and convert to a milder form of estrogen, estrone, when we hit menopause. But this belief that menopause is an estrogen deficiency, that women are not just physically dried up, but we're like sexually dried up and emotionally dried up and creatively dried up, has been a myth that's been perpetuating the rampant prescription of hormone replacement therapy for decades now. And yes, it has a role for women who are experiencing significant discomfort in perimenopause, but to prescribe it just because you're a woman and you shouldn't have lower estrogen, like it's this cure, it's this fountain of youth, as if we're supposed to stay 30 forever or physiologically 30 forever. These are just a few examples. Other, I think, really important examples is the medicalization and the shaming of body odors. Everyone has a vaginal scent, and that vaginal scent is a really important indicator of our well-being. And people ask me, what's a vagina supposed to smell like? Well, it's supposed to smell like a vagina, and it depends on where you are in your cycle and where you are in your life cycles. But also, if it's, if there's a very unpleasant odor, that is important to know and give us an indication of something going on. But we have been so taught to suppress our body odors, right? Like just douches and other things that we actually know are harmful for women's health.
Yes,
so the list
absolutely.
goes on and
Yep.
on and on and on of all the ways that our normal functions have been over medicalized or suppressed.
Yeah, it's like the premise, the philosophical premise is that a woman's body is a lemon. It's like,
Yes,
the woman's
exactly.
body is a lemon, and it's, always going to break down, and it's always going to need some type of mechanical repair in some way.
Exactly.
Yeah. So let's contrast.
And we certainly can't be our own mechanic, right? So we have to go into the
Right.
mechanic shop for the
Exactly.
parts because
Right.
someone else knows better than we do.
Right, exactly. So I wanted to contrast that with exposome science. And this is, and I'll let you explain it because I have never heard of this term before you presented it with your book. And I would love for you to, paint the picture of what that is and what that looks like.
Yes. So exposome science is actually a growing field of medicine and scientific research. It's about 15 years old now. It's established at major universities like Columbia University has a research branch there. And it arose out of the fields of toxicology and environmental medicine. So in conventional medicine, we do have an understanding, for example, that high levels of lead can cause brain damage. In the worst, IQ impairment and cognitive impairment and all of that. We have an understanding that environmental exposures can be harmful. But when we get down to it, most doctors don't really have any more understanding than this very vague sense and don't really do much of it at all in clinical medicine, unless maybe they're working with occupational health and they're working with people who work in factories and farms and things like that. Outside of that, there is toxicology, which studies the impact of environmental toxins and natural botanical toxins, all kinds of toxins on human physiology, and environmental medicine. And over the past couple of decades, there's been this growing awareness of just how significant an impact herbicides, pesticides, heavy metals, but not just those, stress as an environmental toxin, the impact of how we live and how we eat on our microbiome, nutritional deficiencies, and that as human beings, our health is the product of the combination of our external ecosystems, or what we are exposed to, so the exposome, and our internal ecosystems. So for example, our stress tolerance, our history of trauma, our nutritional status, the inherent health of our microbiome, because maybe we were born by C-section or had a ton of antibiotics. And so there's actually now a well-established field of research around how all these variables impact human health. For me, this is the missing link in how conventional medicine approaches conditions. In conventional medicine, let's say you have diabetes. Something's wrong. You're thirsty all the time. You're peeing all the time. You're tired all the time. You go to your doctor, and your doctor runs some blood tests and discovers you have diabetes. It's as if the diabetes started right then when you got the diagnosis. And there's no consideration really of all the factors that led to it. I mean, we know diet, we know things that happen, but we don't really address any of that. We just basically say, okay, now we have a diagnosis. The next thing to do, and the only thing to do, is make sure you're not getting too much sugar in your diet, and to make sure you're on the proper blood sugar controlling medications. Whereas from the perspective of this exposome approach, or more simply called a root cause approach, we would say, okay, what's actually going on here? Let's look at the diet. Let's look at the stress levels. Let's look at the circadian rhythm. I mean, all these different factors. And when it comes to women and hormonal and gynecologic health, there is so much that we know. And just to give you like a quick, really poignant example, when I was applying to medical residency, I was deeply interested in the impact of endocrine disruptors on reproductive health. So what does it mean if a woman is being exposed to these environmental toxins her whole life, gets pregnant? How does that play out in her fertility, her pregnancy, etc.? When I was interviewing at a major Ivy League university for residency, and the older white male physician, who happened to be an internationally known endocrinologist, saw my application, he said, "Dr. Romm, you don't believe in that BPA crap, do you?" He literally, I will never forget those words. "You don't believe in that BPA crap, do you?" So now this is, 15 years ago. And I said, "I actually really do, and this will not be the medical residency for me. Thank you very much." But what was interesting is that about a decade later, at that same university, in the reproductive endocrinology department, a gentleman named Hugh Taylor blew the lid wide open, finding and proving and publishing about the significant impact of BPA on pregnancy and the offspring. And so much so that in that state, which was Connecticut, they actually banned BPA in labels, in receipts that were given out at the grocery store, at the pharmacy, and in airline tickets, because the preponderance of people who handle those, both giving them out but also receiving them at shopping, checkout lines, are women. And even just that paper, which had BPA in it, was enough to be affecting fertility, miscarriage, and fetal development. So this has not trickled into conventional medicine at all. Zero, zero. I mean, really not. And so for me, this book is really about helping women to understand, one, you aren't broken. You're not a lemon by any means. And if you are experiencing hormonal or gynecologic challenges, yes, sometimes we do need the hormonal treatment or the ibuprofen or even the surgery. But there are so many things that we can unpack before we get to that point, looking at what's going on with our diet. How is that contributing? What's going on with inflammation? What's going on in the microbiome? What are you being exposed to in the environment that you can actually reduce your exposure to, whether that is actual, plastics, BPS, phthalates, all of that, or stress, which is now known as an environmental toxin, and what can we add to nourish our systems back to health. And within that, there's a really big call to understanding that none of what's going on in your body, your hormones, and your health is your fault. It is really the result of a culmination and combination of years and sometimes decades of these exposures and how they interact with our genetics and our predispositions that get us where we are. And then, of course, there's a lot of solutions, as you've seen with the book, Stephanie.
Yes. And, to your point around the relative impermeability of toxins and this conversation around endocrine disrupting chemicals, I still see very prominent medical doctors in the online space and wherever. They will often say things like, well, doesn't the dose make the poison? And we know, of course, that there's this non-monotonic dose response.
Yeah.
And when for women who are using more products like makeup and shampoo and lotions, and there are no studies, none, like zero,
No.
around what happens when you use 200 products, 300 products,
Yeah.
and the long-term effects of that. So,
Absolutely. And we don't, somebody might say, well, I don't really use that much of any, product. I just put on my soap and, I just use my soap and my lotion and my lipstick. And the reality is that the way hormones work is that it is literally like your entire estrogen load doing all the things estrogen might need to do at any given time would be like the equivalent of one drop of water in an Olympic swimming pool. And so similarly, the amounts that we're getting, a lot of people say, well, we're just getting exposed to parts per million. But if you actually look at hormone measurements,
that's
they're
exactly
parts
right.
per million, right?
Yes, exactly.
And you're
Yeah.
so right. Like, we don't know what these hormones, what these chemicals are doing individually. We also don't know what they're doing in combination. That's never been studied. And almost every single industrial or agricultural or pharmaceutical chemical that is out there has been grandfathered in by, in this country at least, the EPA. Almost none have been studied in women's reproductive health. And even a lot of the pharmaceuticals that we use, almost all of them have been studied in men. So, even when it comes to basic medications, women over 50 take more than half of the medications. Like 70% of the medications are prescribed to women 50 and over. But our metabolism is completely different. We're being given male doses. So often, even our pharmaceuticals can act as disruptors to our natural hormone physiology. Studies have come out in the past few years looking at just even ibuprofen, that
right.
5 days of ibuprofen consecutively, we know, can affect the gut. 10 days of ibuprofen consecutively can actually temporarily impair ovulation, which may sound not significant, but if somebody is having really painful periods every month and they're taking ibuprofen 5, 6, 7 days a month, or higher doses, a few days a month, and then they're not ovulating and they're struggling with their fertility and nobody's kind of looking under the hood, we can be missing a lot of big things.
Yeah. Yeah. And in the book, you'll have to pick up the book to get all those recipes, but you do a lot of sort of clean swaps, which I love,
Yeah.
and my grandmother, so wise, before her time, like she was like, the whole house can be cleaned with vinegar, like you can clean
Totally.
you can clean the floors, you can clean the windows, you can do the sinks and the bathtubs with a little essential oil, vinegar, no dryer sheets. She would always hang her stuff out on those like lines outside.
My grandma too.
Yeah.
My grandma did the little bit of vinegar and newsprint for cleaning the windows. That was her thing. Yeah.
That's great. So let's talk a little bit about menstrual cycles. You mentioned, these anovulatory cycles that women can experience if they, and even really, if you look at some of those genetic SNPs that the liver might have in terms of their ability to detoxify and move the ibuprofen into the intermediate for excretion. I mean, that also adds another layer of complexity. But, I was so thrilled, truly reading. We are so similar because I am so
I can tell.
interested. I'm so interested in how to live for women in their reproductive years. And then also when we move into menopause, different cycles, but how we can live in alignment and in harmony with our menstrual cycle. And you talk about, some of the, intuitive eating and hormonal balancing, and what can happen with hormonal dysregulation and self-care. So why don't we start with what a normal menstrual cycle looks like, and then we can
Yeah.
maybe talk about some of the ways that we can go awry. And I have a feeling that you're like me, and that you're very much particular with words, because I hear people, like I would have women come into my practice and say, I just get these regular headaches. Like I get regular headaches around my period. And I'm like, no, common, not normal, right?
Yeah.
It's a common symptom. It's not necessarily normal.
Yeah,
So
common and normal are so different, right? Because like by definition, normal can mean common. But we exchange common and normal for healthy a lot of times. Like just
right.
because everyone's experiencing it doesn't mean we were meant to experience that. So, okay, so a normal menstrual cycle generally starts somewhere between 12 and 16 years old, and typically we have about 400 menstrual cycles in our life, and then the average international age of menopause is 51. Menopause means you haven't had a period for 1 year, and then you're officially in menopause. All the years in between, keeping in mind that our menstrual cycles are very sensitive. I like to think of the menstrual cycle as like a monthly check-in, because you really have an opportunity to kind of see what's going on in your life, in your world, how it's showing up in your menstrual cycle based on some of these normal parameters that I'll share. But it's also a huge opportunity to course correct. So the normal menstrual cycle should be somewhere between 26 and 34 days long. So if you've got this idea that you have to like have your period at the full moon and ovulate at the new moon, actually it doesn't usually work that way. Very few women globally around the world, that is, have 28-day menstrual cycles. The international average is actually 29.5 days, but anywhere from 26 to 34 days is considered normal. And then it should be about the same length every month, give or take 4 days. So if it's 28 days one month, 32 days the next month, you know, 29 days the next month, 31 days, that's actually still considered normal. If it's less than 26, more than 34, or varying by more than 4 days on average a month, if it varies more than 4 days 1 month, it doesn't matter. It's like fine. You know, if you have one period that's like 25 days, something wonky was going on. Maybe you were traveling, maybe you were sick, maybe you were stressed, maybe you lost sleep because you work a night shift. Those things happen. But if you're seeing these patterns for 3 or more consecutive months, that's kind of when a heads up. Or unless you have a serious symptom that's new, like suddenly you have new pain. Your period shouldn't require you to change pads or tampons more than 6 times a day. And it shouldn't require because you shouldn't be bleeding through them more than that. They shouldn't be saturated 6 times a day. You should never have to double up just to get through your cycle. And you should never have to double up on like a maxi pad, because then that is a sign of heavy bleeding. They shouldn't last more than 7 days. So a heavy period is more than 6 pads or tampons a day, having to do things to like work your life around your cycle. Like, oh, I can't go play soccer that day because I'm going to hemorrhage through my pads. Like if that's happening, that's interfering with your life. That's a heavy period. Or if you're bleeding more than 7 days. Conversely, if you barely ever have to change your pad and or bleeding less than 3 days, that's not usual either. That's considered something's going on, low estrogen or something. Ovulation usually happens about 14 days, give or take, before menstruation. And ideally, we may notice some changes in our mood, our behavior, the things we're interested in, the forms of exercise, things like that we want to do around ovulation. And we may notice some changes in our mood. Premenstrually, we may feel a little bit more like staying home or reading a book or watching Netflix, but not like going out to the party premenstrual. That's all normal. You may feel a little pelvic fullness premenstrually, even a little tiny bit of aching, because it's a naturally slightly more inflammatory process. But you should never have to take ibuprofen or Tylenol or Aleve or anything like that, Motrin, for your period. When I say never, I mean, obviously, if you're under significant stress, if something's going on, it may be like a one-off thing. But if you're having to take it every month, if you're having to take it for a full day every month, then something else is going on. Either there's inflammation, endometriosis, something that should be explored. I'm trying to think of what else. I mean, it's normal to have like a little tiny bit of water retention because of the prostaglandins that we're producing. It's normal to have a little bit of breast fullness, but anything that's actually making you uncomfortable, and certainly anything that's getting in the way of your quality of life or the ability to do anything. Like you should not be able to do anything, except I've heard that you can't go to the Komodo Dragon National Park during your period because they're so sensitive to blood that they will attack a menstruating woman. But
Oh
aside from
my
that,
goodness.
I know. I have a 6-year-old grandchild, and he loves these like survival things. So we just learned that last week that
That is a good
menstruating
piece of
women,
information. Wow.
right, never pee if you're being attacked by a tiger because they will think you're marking your territory, and never go around a Komodo dragon if you're menstruating. So, other than that, there's nothing we can't do. So if there's something you don't want to do, that's your choice, right? Like that's your own proclivity. But if there's something taking you out, that's not normal anymore. That's kind of the rundown on what a normal menstrual cycle is. It's normal to have clots periodically. Not you don't want to be clotting up all the time. Something's going on if you're having clots regularly in your menstrual cycle. A lot of teenagers do, and it's pretty normal. But if you're having clots that are bigger than the size of a quarter, if you're frequently having clots, that's also a sign that you're having heavy bleeding and you want to get that checked out. So there are a lot of things on the internet, like your period blood should look like this for healthy period blood. A lot of that is exaggerated and creates beautiful brands that people have around hormone health, but it's often this very reductionist, overly simplified way of, or overly complicated in some ways, way of kind of like adding more pathology when there isn't.
So if there is some sort of hormonal dysregulation, if there's a
Yeah.
woman listening now and she's saying, yeah, you know what, I do have to double up on those maxi pads. Like I actually, I wrote about this in my book where I knew that the day that I would get my period, I had to bring at least 2 pairs of pants with me because I knew if I got
Mm-hmm.
not stuck, but if I was in an initial appointment with someone where they're
Yeah.
typically longer and I was sitting, I knew that the chair was going to be like, I was going to bleed through the pants. And that was just my own.
It's really stressful, right? I mean, when I went into menopause, well, before I hit menopause at 54, but that like 6 months before, I was having these irregular cycles. And one night I was like sitting on my sofa in my living room. It's a gray sofa. And I got up and I had started bleeding. And because I was having like, just like 3 weeks and then 5 weeks. And I got up and I was like, oh my gosh, I forgot what this was like from being a teenager.
Right.
My daughter was there. She's like, Mom, this is so teenagery. But it's stressful for women who experience that. So many women have told me like, oh, like I sit sideways in my chair, like without anyone noticing because I don't want to get up and there to be blood on the chair, or I always have a sweater I can throw around my waist, and so awkward. So if that is happening, there are a number of things to look at. First, there is a condition that's a genetic condition called von Willebrand syndrome that often doesn't get picked up in teenagers and women until their 20s. So if you are having like just gusher, hemorrhagic level periods, it is worth actually getting your genetics checked to see if that's part of what's going on. It's really important to look at our estrogen levels. Some women do naturally produce a lot of estrogen, but we're getting a lot of estrogen from our environment. That can make us have really heavy periods. And then also, if you're having very irregular periods, so the periods are quite far apart, and then you do bleed, if that endometrial lining has been building up for months, you're more apt to have a quite heavy period. So those are some of the things to look at. And then anyone who is having really heavy periods, you may be more likely to be a little bit anemic or a lot anemic, and you might feel more tired and a little more brain foggy and sluggish. So getting your iron levels checked is really important too.
And one of the things that we often hear when a woman will present to her, PCP, her primary care physician, is she'll get a script for the pill, right? Like she'll get a script for heavy bleed. You have acne, you have this, you have abnormal periods. Like let's give you the pill.
You have a uterus, you have breasts. Let's just give you.
Yes. You have a uterus. You know what? You have a lack of you have a lack of this hormonal contraception. So why can't some of these, in aggregate, we can say maybe some of these symptoms will, they line up with premenstrual syndrome, maybe not so much the bleeding, but like, the water retention, the heavy breasts, maybe the mood, irritability, depression, anxiety. Why can't that be fixed with the pill? Can you explain a little bit about why
Well,
this is not, or
yeah.
maybe it is a solution in some cases, but why is it not sort of like, you know, when we're painting broad strokes, why can't this solve all of our ails?
Yeah. So, I mean, the pill, serotonin reuptake inhibitors, antidepressants, which are sometimes used effectively for premenstrual syndrome, especially the emotional components of it, they can help with symptoms in a lot of women. So I don't want to just say, these are off the table, never use them. And I don't want anyone to feel judged or ashamed if they are using them and they are getting good results. But the bottom line is what those do is they suppress your ovarian function. They are suppressing your natural hormonal cycles and giving you an alternative hormonal kind of flat line. And so what's happening is that you're getting symptom resolution, but without ever getting to the underlying causes. And the problem with that is that those underlying causes, whether it is inflammation, can show up later in other ways. If it is high levels of estrogen, that can show up later in other ways. So looking, to the underlying causes becomes much more deeply therapeutic. You're actually resolving what's causing the problem, and you're resolving things that can lead to other things. So for example, with polycystic ovary syndrome, one of the underlying problems is metabolic disruption, right? The insulin resistance is often a piece of that. So just giving a woman the pill may help with her acne. It may help with giving, medication may help with hair loss. It may help with certain of the symptoms. And that can be tremendous. I mean, living with cystic acne can cause severe depression, social anxiety, and disrupt someone's life. But if we don't address the insulin resistance, that can still show up later as prediabetes, metabolic syndrome, diabetes, and have all the lifelong consequences of untreated diabetes. So you think you're getting treated, but you're not. And then it shows up later. And that's a problem. And I've had so many women who were put on the pill. I'm sure you've seen this too, Stephanie. They were put on the pill when they were teenagers for acne, irregular periods, all the whatnots that get us put on the pill. And then they come off it when they're 32, ready to have a baby. They want to get pregnant, and they're not having their cycles, or their cycles are right back to irregular, or the acne has come right back because they've basically spent, 15, 17 years having their cycles and symptoms suppressed. Boom, they're off of it. And now they're facing that again, and first have to treat that before they get pregnant. So it's really important to look under the hood.
Yeah, and that's important because I think that there still exists a narrative, and I've seen OBGYNs really poo-poo this idea that the pill could ever affect fertility after the cessation of it. Like
Yeah.
I've yeah, and for some people, it's not an issue, right? Like they take the pill,
No.
they get off it, they're pregnant, they're happy, no
Yep.
worries. But for some, and I remember when I wanted a baby, I wanted to get pregnant, and it couldn't happen, and I was
Sooner.
pregnant I was pregnant in the second month of trying, but that first month when I got my period, I was like, oh my God, what is wrong? Like, so you have to be a little, I think there requires some sensitivity and compassion, because there are women, as you were saying, on the pill for decades and, don't really think twice about it. And then they do have trouble, reinitiating that brain ovarian, that
Axis.
that axis.
Exactly. Yeah. I mean, 80% statistically of women who come off the pill will cycle again within 3 months and have normal cycles. But what we don't account for is that 60% of women who are on the pill are on it for non-hormonal contraception. They're already on it for a hormone imbalance. So my suspicion is, if were the studies to be done, which they haven't, we were to look at the women who went on it for non-contraceptive reasons, but who went on it for hormonal problems,
Right.
that would probably be where we saw that higher proportion of women who come off it and they're right back to facing those problems again.
Mm-hmm. Let's talk about a couple of ways that women can live in harmony with their cycles as it relates
Mm-hmm.
to, self-care and slowing down, and when to speed up, and when, we're recording this, on a full moon. So I hope we're infusing some of that full moon energy into this
I love it. This
conversation.
isn't just a full moon. This is like the full blood flower moon lunar eclipse. And we've got some major action happening here. Like
Yes.
some major feminine spiritual action here.
I love it. And so I think
I
it's
know.
it's a great time to think about how we can use the wisdom of that ever-changing, hormonal milieu to be able to integrate that into our workflow and productivity and self-care. Can you shed some light on why those things are important for us to consider in our menstrual cycle?
Yes. I mean, we live in a, however you cut it, what's that old James Brown song? It's a man's world.
Oh yeah.
And,
Hmm.
there's a very, the way our entire culture is set up is really around strive and drive and taking time off or stepping back or setting boundaries isn't really considered the way to be successful. Listening to our bodies is not considered the way to be successful. We override our bodies all the time with caffeine and in some professions, other stimulants. And so we're really driven to keep up with this very male dominated industrial or post industrial work schedule that doesn't take into account nature and natural rhythms. And not to sound woo woo or biologically reductionist, I'm not saying everyone needs to go into a red tent every month and howl at the moon unless you want to. Tonight would probably be a great night to howl at the moon. Actually, I might just actually have to do that with the coyotes that live out back. But to start to pay attention to that natural cyclic rhythmic biology that we have. And if yours isn't cyclic, that's okay too. If it's irregular, that's okay too. But to start to do what I jokingly call me search instead of research, just start paying attention to what you notice throughout your cycle. I love writing it down, but it's so funny here. I just happen to have on my desk because I was going to do a video of these, but these are my moon charts from back all the way to these go back to like 1982, I think, or 1981. These are my lunar charts. I have all these different beautiful lunar charts.
Oh wow, look at that.
But having there's so many different kinds too. This one. Having that ability to either paper chart or use a tracker and start to pay attention to how long is my period? How many days is it lasting? When do I start to notice that actually I'm kind of wanting to go within and I'm getting really irritable and cranky because I'm not able to and I need a break from, taking care of the kids, or I need a day off, or I need to just get out into nature. And just start to notice, because I think even in noticing, even if you can't not show up at your day job that day because, you have to show up, but noting, okay, I feel different, rather than like, what's wrong with me? I'm tired, I'm cranky, I'm irritable, or having it, externalize where you're acting it out. You can just say, all right, right now I'm wanting to do that and I'm forced to do this. And it's creating a schism between what I need and what I can do. Sometimes just even acknowledging that and honoring that can be incredibly liberating emotionally. Starting to pay attention to who you're drawn to and who you're attracted to, whether that's emotionally or spiritually or sexually throughout your cycle. When are you inclined to do certain kinds of exercise? If you start a brand new, like high intensity workout 3 days before your period, you're much less likely to stick with it because our pain threshold goes down, our muscle function actually changes a little bit premenstrually. So that may be a better time to do yoga or some gentle Pilates or take a walk in nature. Whereas right after your period, as you're moving into that upswing of ovulation hormonally, that's a great time to do that 3 day, juice cleanse that you were wanting to do, or do that brand new CrossFit program, or, hiking, high intensity hiking, because it's more physiologically aligned. If you notice that you're paying attention to your food cravings, we know from a lot of studies now, Marty Hazelton's done some of this work, for example, on research on it. She's looked at how we shift throughout our cycles. We may be more inclined to eat more lightly And there are evolutionary biology reasons for this around ovulation, but we may be more inclined to crave carbs or fats or sugar premenstrually. If you know that and can anticipate that, you can have a really beautiful organic brown rice pudding with almond butter, or a chocolate chia seed pudding, or even just some dark chocolate and some berries, instead of hitting up that like bag of cookies. So anticipating these things can be really, in the least, just really interesting and fun, and at best can give you an enormous amount of data around how your physiology influences your life experience, and also how your world influences your physiology and your inner world. It's very beautiful.
It really
And
is.
all you
And
have to do is start tracking and pay attention. Like, that's all you have to. And it's not like you have to like meticulously track. You can just have a notebook or a journal, or have a calendar like this. You can get there's zillions online. Have a calendar, stick it in a notebook, and then just like make a little note in the morning, or make a little note at the end of the day. Oh, like, this is what I was going through, and here's how I'm starting to see patterns.
I love that. And I think it's so, this is one of the ways I think that as women, we stop acting like we're little men, right? Where we kind
Yes.
of divorce ourselves from the patriarchy in a way and say, this is how I need to attend to my soil today, right? Like, I'm going to
Mm-hmm.
either do this big high intensity thing about to ovulate, or, or I'm going to go for the walk. I'm going to do the Pilates. I'm going to, maybe have some journaling time. And there's no white knuckling, right? When we're
Yes, I
trying,
love that.
yeah. I think that when we try to eat the same way, I mean, I tried this for years. I sort of talk about this in my book, how this journey that I always like, I pretended like I was a little man as long as I could, right? Totally ignoring my own physiology. And I would literally like try to hold on for dear life that week 4. And I wanted the carbs and was denying myself. And then what ends up happening is you clear out the pantry, right? Like, you eat the cookies, you eat the chips, you eat the crackers. So
And if you do, that's all good too. But if it's not making you feel great,
right,
that's the thing. It's like, how
right,
do we have, I don't like the term controlling our hormones, because I don't, again, that's the little men thing, right? Like the
right.
control, this idea of controlling nature. But how do we have a sense of more agency over ourselves, rather than feeling like we're being whipped around by our hormones? Because if we feel like we're being whipped around by our hormones, that's often when there's something out of balance. And it doesn't mean it's out of balance with your hormones. It could mean that your lived experience is on your needs. Your actual needs are in conflict with your environment or your world in some way. And so how do we rethink that? How do we grab that space for ourselves for, 2 hours on that day right before our period, when if we just knew that we had that 2 hours to take that bath or take that walk and write in our journal and have that cup of tea, it would nourish us and decompress us, so that we're not, I love that idea of like white knuckling through. That adds to the stress and the tension and the inflammation and the agitation that ultimately just makes us explode.
Right. Right. So much wisdom there. And I want to make sure that we touch on menopause, because this is,
Mm-hmm.
whenever I talk about cycles, my lived women, my well-lived women that follow me, like, what about menopause? What about us? Because it often seems like this is a cohort that is often ignored. We tend to
Yeah.
say, well, you're not a woman anymore. You're not reproductively useful. So
Yep.
no more sexuality. You might as well just, whatever.
Crawl under a rock.
I-
Go into go into the grandma cave.
Exactly. Exactly.
Disappear.
Yeah.
It's interesting, and it's funny because when I was writing the book initially, I had a whole section on menopause, and then my publisher said, "This book is getting too long, Aviva. I think you should take out the menopause section." And I said, yeah, no, that's not happening. The menopause section is going in here for 2 reasons. Half of all women are in menopause now, or half of all women are over their 50 or 50 and over in the United States, and also, I'm not going to make that group of women disappear, right? This is a
Right.
group of women that needs to be heard. And I want this book to be a book that whenever you get it, like if you get it in your 20s, you're still looking at it in your 40s and 50s. If you get it in your 30s, you're giving a copy to your mom. If you get it in your 40s, you're giving a copy to your daughter and your niece and your mom. I want it to have that longevity. And yes, I mean, it is such a time where culturally and historically in the Western world, right, in almost any indigenous culture that I've ever studied, learned about, or visited, the elders are revered. In our culture, I mean, you don't have to be elderly. You just be 50 and or 50, 48 and over, or say you're in menopause and now you're in like this old category. Interestingly, women in our 50s and older have more and better sex than any population. Really interesting. More orgasms, better orgasms, more sex, more fulfilling sex, because we know what we want, we know what we like. We're more confident in expressing it. We're more comfortable in our bodies. Really interesting. Whereas women in their 20s are having less sex than the last 3 generations, partly because everyone's on electronics and not making time for intimacy. So we can learn a lot about comfort in our bodies and, just juiciness and confidence as we age, which is really beautiful and powerful. I think we need to just completely reframe this word aging. I like to consider these the queen years because I'm almost 55. I don't feel like I'm a crone. Crone feels
Oh, they have the worst
much,
names too, like crone, and
yeah,
even if you
and
think
I
of
don't mind,
hag, like these words.
yeah, hag, I know. I don't mind crone only because it's such an old word. And like that triple goddess was mother, maiden, or maiden, mother, crone. But there feels like
Oh,
there's something in between there to me that is like these very rich years of, we're not in our 80s, 90s, but we're in this other phase. And think about this, we have like 30, 40, 50 years after menopause, depending on when we go into it, and hopefully having a very long life. That's a substantial amount of time.
yeah.
That said, just like with any of the other, cumulative environmental exposures, lifelong exposures, and insults that have happened with nutrition, microbiome, stress, oxidative stress, inflammation, all of that, it is a time when, as we shift from the dominant form of estrogen we've had most of our lives, estradiol, to a less potent form, estrone. The estradiol is more protective against inflammation. It's more highly metabolic, so we burn more fat when we have estradiol. It creates more proliferative, tissue. So our tissue is plumper and juicier. Our breasts are fuller. Our vaginal tissue is fuller. So as we transition into that estrone, we may be more predisposed to developing autoimmune conditions if we have higher inflammation or autoimmunity gets triggered. We may experience sleep problems as progesterone goes down, vaginal dryness or urinary infection or urinary inflammation, irritation as estradiol goes down and estrone comes on, hot flashes and night sweats, migraines as estrogen drops and plummets. So there are symptoms that I think like with menses, like with having our periods and our cycles, it shouldn't cause us misery or disruptive discomfort. And if it is, then we want to look to what are the imbalances, again, in the environment, in the ecosystems, in our diet, in our sleep, in our stress, all of that. And what can we do to restore and support and nurture? For some women, that may be using a small dose of hormones, but there's so much we can do along the way. And like with the pill, we can't use hormone replacement therapy in the same way, right? Like you're a woman in menopause, you have a uterus, you had a uterus, you have breasts, take the pill, take the HRT. And similarly, like we don't with the pill, we don't adequately educate women about the risks. We don't adequately educate women about the natural alternatives and what we can do. And we don't check in, right? Like the way women get put on the pill at 15, 16, 20, whatever, and don't come off it until usually they're ready to have a baby. That's the usual reason people come off it if they do. We put women on HRT, hormone replacement therapy, at 48, 50, 52. And then maybe at 60, somebody's like, oh, you're still taking that? Do you still need that? And then we finally, after these, a decade or more of estrogen exposure or hormone exposure, we think, oh, right. Didn't see that risk coming. So, I want us to use the therapies that make us feel more comfortable. I really, the power of reframing aging and menopause is so important. I actually didn't anticipate personally. I had very good fortune. I had very easy menstrual cycles my whole life, no gynecologic problems, got pregnant at the drop of a hat, easy home births, easy breastfeeding. I mean, honestly, it's been very smooth for me. I've been very, very fortunate. And not so much for my mom. My mom struggled with period pain, ovarian cysts, thyroid problems, all kinds of stuff. But I did not anticipate the experience of transitioning into perimenopause, just like simple changes in my muscle tone in my face or changes in my hair, and how that felt, especially in the wellness world, where women are already, I mean, women who are like inarguably gorgeous fashion model kind of people who are already like picture perfect, getting Botox at 30 or breast jobs at 32 and filler and what that means when you are aging naturally and you're up against a culture that really already when we're 30 is telling us
Yes.
we should be doing something to fix ourselves. And it was more, honestly, more challenging. The other thing I found challenging is, when we're going through puberty or going into puberty, even though it's hard in so many ways, and I don't think any of us would want to go through puberty again if we had the choice of a part of our lives to relive, that would probably not be it. We're anticipating the excitement of becoming adults and gaining our autonomy and becoming women. When we become pregnant and become mothers, we're transitioning into something that's a very new, welcome realm. But when we go into menopause, our culture doesn't transition us into this now wise, revered, valued, experienced member of the community who's also freed up to be a complete freaking powerhouse because your kids are grown and you're not having to think about,
Yes. Yes.
making dinner at a certain time if you're working on a project and you're inspired. But I didn't anticipate, and it's really causing me a lot of thought of how important it is to. I've even been considering creating an online menopause celebration, just for women to, have that time together to really celebrate it. And I find myself looking to some of the most incredible role models. I mean, Michelle Obama at 58, showing up on a talk show with like a cutout top and like very empowered and obviously in her sexuality and in herself as a creative being, or Helen Mirren or Yoko Ono, who's like killing it at like in her 80s and still
Yes.
like,
Mm-hmm.
looking to these role models for a new definition of what it is to be a fully embodied, creative, sexual, empowered being at any age, and just redefining it. And it does require a lot of defying our culture, but also in our own story to ourselves.
Yeah. And you talk about this idea of honoring your womb, like whether it is, making, has the capacity for making babies or we're in menopause. And I think, I've talked about this again, very much aligned with you. I think that our wombs are the ultimate alchemists. Like we can, when you honor the creative prowess and the capacity to turn pain into power,
Mm-hmm.
through the womb. I think that, any woman of any age, if we can tap into that, you might call it the root chakra, the sacral chakra, these energetic points,
Yeah,
and I think are so powerful. And I think, as you're saying, if a woman can begin to redefine these stories, these belief systems that she has, then she can begin to fully step into who she's truly meant to be, whether or not that conforms with, societal or the culturative norms at the time. Because we also know that those things
totally.
change. Like I grew up, Kate Moss was the body type, and
Yeah.
I'm like, I'm Portuguese, like that's never going to happen. Like I have a butt, like there's no way that I'm
Yeah.
ever going to look like that. And now we sort of see that it's sort of this Kardashian type of very
Totally.
voluminous, body, but also understanding that in 10 years and 20 years it's going to be something different. So when
Yeah.
this target
And
always
to add
moves.
to, yes, I love that. And also to add to that, a lot of times when I'll write something about womb wisdom or womb power, I'll really acknowledge, to those women. As I said, 30% of women over 60 will have a hysterectomy. So
Right.
I really want to acknowledge, like, to those people who have had their womb removed for any reason that you've had that done. I think of it as like, how people say when they have a phantom limb, they can
Yes.
still feel
Yeah.
it there because the
Yeah.
neurologic connection is still there. And so even if you've had your womb removed, you can still tap into that energetic power, still tap into those life force connections that we're talking about, that transformative power is still there. And so don't, despair if that has been the case for you. You can totally just drop right into that space.
That's great. Yeah. And there's that divine connection that I think that is really, I mean, we all, and I think to become a medical doctor, to do the work, I'm a chiropractor by training. So, to go through, that type of schooling, you have to be able to channel that masculine energy, like achieve, achieve, achieve.
Totally.
So many of us, myself included, I really have to think about dropping into my feminine, to slow
Yep.
down and to think, because otherwise I'm very, very comfortable running myself into the ground. Like I'll forget, like it's just, and I think many women,
Totally.
you don't have to be a doctor. Like it's just, you have life. Like there's so many things coming
Yeah.
at you all the time. And the boundaries that you're talking about, very feminine endeavor. It's like, this is what's okay. And this is what's not, right?
Well, there's so much scarcity. There's so much fear. I mean, people's socioeconomic situations may cause them. My mom was a single mom in a housing project. She had to work 2 jobs and then come
Right.
home and take care of 2 kids. I mean, sometimes circumstances just really require us to push. And sometimes we're just people who are very inspired. Clearly you are, clearly I am, with a lot of drive and commitment to accomplish or create or make change. I think of it as elastic, and I think of the term resilience as a piece of elastic. Because if you stretch a piece of elastic not beyond its capacity, and then you let it go and you stretch it you can pretty much do that forever, as long as you are not going beyond the capacity and as long as you are letting go. It's when we stretch a piece of elastic beyond its capacity or keep it in that place for too long that ultimately those fibers break down and it loses its ability to rebound. So even I've right now with this book launch, I mean, it's an incredible amount of work, incredible, and a lot of hours. It reminds me of being in residency in some ways. But then I also know that I'm building in time each day where I hit pause, decompress, don't let myself go back on the computer, build in time each week, even if it's a couple of hours to read a novel and be off electronics, and then build in time after that push. So I know I have time that I'm going to hit pause to some extent after the launch and regroup. And I think that is so key is, are we pushing and resting, or are we just constantly in this incessant go? And that's where we get stuck.
Yeah. And I think that that's, when we talk about chronic low grade stress, chronic low
Yeah.
grade inflammation, unresolved trauma that lives in the nervous system. It's that
Oof, yeah.
pulling. I love that. I love that analogy around sort of bringing it to its, its capacity. It's like the matter's capacity and then releasing
Yeah.
so much of the time. We're always like just right here, like just, this frenetic, energetic vibration. So I think that that's really important, even as a very simple, how you start your day, how you close the day. These can be 5-minute, 3-minute practices sometimes, especially if you have little ones running around.
Yeah, those are 2 things I'm really committed to, is how I start and end my day. So I really try to start my day without getting onto electronics right away, just more have a
Great.
slow start. And even when my kids were little and breastfeeding, or they're jumping on you, even if you need to set your alarm to get up 15 minutes earlier before you get the kids ready for their day, if they're going out to school. But if the baby comes in, or toddler comes in to nurse, or the kids are clamoring, you snuggle them in. Everyone can do a few minutes of breathing together, and then at the end of the day, that no electronics, ideally an hour before bed. Read an analog, like read an actual physical book, not a Kindle or anything like that, and just do a few minutes of deep breathing. I think journaling is really powerful too, for that ability to dive in and connect in with ourselves and just kind of feel. I know for me, I get very stuck between here and here. And obviously, like, a lot of my work is talking and teaching and thinking and writing. And so just dropping in by doing some soft belly breathing, letting my belly unzip, like we zip ourselves in as women, like letting my belly relax, breathing into my belly, expanding, all of that. It's like right before bed and in the morning makes a huge difference.
So juicy. I love it.
Mm.
Tell everybody where they can find the book. This is something that
Yeah.
I've had the pleasure of reading. It is, as you said, I think it is absolutely a perennial bestseller. I think it'll be something
Thank
that
you.
generations to come will be able to talk about. And that's actually that's what I hope, a book like this will achieve, where you have women of different generations talking about the experience of being a woman and how we can start sharing stories with our girls, our up and coming girls, so that they don't carry on this sort of, baggage or, this,
Yeah.
trauma or this, ancestral lineage that we pass on to them because we're not awake to some of these changes. So where can we find your book? It's called Hormone Intelligence. And then where can people interact with you if they want to find out more about you, your work, your practice?
Okay, so first of all, I just want to tell you, I could talk with you all day and listen to you all day. This is lovely. I love this conversation.
Me too.
And for those of you, thank you. For those of you who want to get a copy of Hormone Intelligence, get it anywhere that you love getting books. In Canada, I don't know the exact release date, so I would check on Amazon Canada, and that there is a link to that over at my website, avivaromm.com/book. Wherever you get your book, and I love it if you can support independent bookstores too. They really need our support and help right now. But then go wherever you get your book, go to avivaromm.com/book, because there are some seriously juicy gifts for you. If you pre-order my book by June 8th, you will get completely free access to my 28-day gut reset, which is, if I say so myself, it's an incredible program. There's even a baby named Avi after me, whose mom got pregnant after 2 years of an infertility diagnosis, had tried everything, did the reset, and then 2 months later she was pregnant. So we've had some really incredible results with that. And it's also a gorgeous, nourishing program. You will also have access anytime you pre-order or purchase the book. It goes officially on sale June 8th. But if you purchase the book anytime between now and the end of June, you will have access to either a ticket to or the replay for a full evening and full day event with me and 12 other teachers who will be talking about women's hormonal health, interaction with the medical model, so many wonderful things. And that's going to be introducing Ricky Lake and Abby Epstein, introducing me and interviewing me about the book. And that's June 4th, 5th. But again, you'll have replay access anytime that you buy the book through June. Once you're there at the avivaromm.com/book page, you'll see the instructions, but you're also then in my website. So if you opt in for the book and those gifts, you'll be in my newsletter, which we generally do once a week. It's a new blog, podcast, etc. So you'll kind of get all the deets on what I'm doing there. We don't sell the list. We don't do any marketing other than when I have a course or something. The other places to hang out with me are my Instagram, dr.avivaromm, or Facebook, Aviva Romm MD. That's where I live. I am starting a new form of medical practice in September, October 2021, which is going to be a group medical practice, so I can reach more women, but also offer a new experience. So I'm also very excited about that. And you'll learn about that when I post about it, either in my newsletter or on my social media. That's about it for me, basically.
So generous. I like those gifts and bonuses. Those are exciting to me. I'm going to definitely opt in for those. I love that. All right. Well, this has just been such a delightful conversation. Really just a treat for me. As I said, I've been, aware of you, following you, your protocols and your work, and you have just profoundly influenced me as a mother, as a doctor, and, the work that I'm putting out in this world. So I
can't wait to read your book. So
yes.
I'm all about it. I'm going to be getting a copy of it myself. So
yes, I'm sending you one after this conversation.
Oh, thank you.
Yeah,
thank you. Great. Thank you, everybody. And thank you so much, Stephanie.
Dr. Stephen Gundry is the video that's coming up next for you. Just click right here. We're talking about the microbiome, energy, postbiotics, mitochondria, and how to get your energy back.
Continuous ketosis, 24 hours, 7 days a week, 365 days a year is really dumb.